Because imagine you are going through perimenopause and menopause. You're sweating uncontrollably. You could be sitting in a meeting and it can happen. You could be giving a presentation and it can happen. You find it harder to complete tasks. You're struggling with sleep. And underneath the surface, you are losing bone mass and you're losing muscle mass. Both things that can later impact the quality of your life. Hi, this is Shyama. I'm excited to introduce today two topics, perimenopause and menopause. I want to go through some basics, explain and define what these two words mean, then go through what are common symptoms that women describe when they're going through perimenopause and menopause, then talk about how common these symptoms are and how we as physicians diagnose this, what are some natural remedies for the symptoms, and what are some prescription remedies. So we'll start with definitions. Perimenopause is a transition phase that starts about 2 to 3 years before menopause. It's divided into early and late perimenopause. Early perimenopause is when periods start to become a little bit more variable. You may go more than 7 days late from your regular cycle. And then late menopause is usually characterized by missing a cycle for more than 60 days. Then this irregular cycle continues until the last menstrual cycle. Then we define menopause as the absence of a period for 12 months. So a lot of times women will come in and have missed periods for about 6 months and are having symptoms and worry that they're already in menopause. But the definition of menopause is the absence of a cycle for 12 months. The average age of menopause is about 52 years old. It can range anywhere from mid-40s to late 50s. Generally, if you're going without a period for a year and you're younger than 40, we need to look for other causes of that. So the most common symptoms of perimenopause are irregular periods. Women start to notice this usually in conjunction with hot flashes and night sweats. They might start to notice sleep changes, more irregular patterns of sleep, some mood lability, meaning like you're feeling more irritable, a little bit more anxious, maybe some depressive symptoms. And commonly, women will describe something called a brain fog, where they start to notice that their memory is not working as well. Tasks that they used to do easily are becoming a little bit more difficult. Sometimes we'll notice fatigue, headache, some weight gain, and specifically women will describe weight redistribution, meaning the weight seems to settle into our lower abdomen area and in our hips. And also you start to notice decreased libido. Then when you get into menopausal symptoms, it's similar things, but often a little bit more intense. The hot flashes can get worse. You start to notice more dryness in the vaginal area, so sex could become more uncomfortable. You might start to have more urinary tract symptoms, maybe even recurrent urinary infections. The mood changes, sleep changes, cognitive changes could all become a little worse. Some women notice joint pain. And in addition, you might notice hair loss, kind of thinning of the hair. The hairdresser might notice, or you might notice clumps of hair shedding more regularly. So we classify the hot flashes, night sweats as vasomotor symptoms and the vaginal symptoms as genitourinary. And it's interesting how many women actually experience these things. All women go through perimenopause and menopause. Some women seem to go through it with fewer symptoms, others with more symptoms. It's hard to predict how people will experience it. Anecdotally, we think that women that are exercising more regularly and generally having a healthier lifestyle may experience less symptoms, but that is not always the case. I see women who are extremely active and fit and very health conscious, having horrible hot flashes, vaginal dryness, mood changes, cognitive changes. So we all experience these symptoms at differing degrees. So the prevalence of these symptoms is remarkable. all women go through perimenopause and menopause, and approximately 85% of women will experience some symptoms during this transition. Of course, it varies based on our genetics, based on our lifestyle, but the important thing to recognize is that we all experience these symptoms to some degree, and some of us for longer than others, some of us more intensely than others. And yet it's fascinating that despite 85% of women experiencing this, often clinicians aren't addressing it with women until they bring it up themselves. And I'm guilty of this as well. So it's interesting to think if 85% of men were complaining of these symptoms, we're probably doing a lot of research, a lot more research, and it would be on the front page of all magazines. But enough women are talking to other women, friends, family, and their clinicians, and hopefully finding solutions, because there are plenty of solutions available. Next, I want to talk about how you diagnose perimenopause and menopause. Perimenopause is a purely clinical diagnosis, so it's generally based on the symptoms that we described and the symptoms happening in our late 40s. So age is the first clue, and then the irregular periods, and then the onset of the other symptoms: hot flashes, night sweats, cognitive changes, sleep changes, mood changes. Menopause is diagnosed by the absence of a period for 12 months. Often women will come in and ask for blood tests during the perimenopause and menopausal period. Unfortunately, the blood tests don't help us very much because as you cycle naturally, there's a fluctuation of your estrogen and progesterone. So if I check your hormone levels in the perimenopausal phase, they just could be varying based on the time in your cycle. So really, your symptoms are the main factor directing our treatment. Once you've gone 12 months without a period, we can often check a hormone level called your follicle stimulating hormone, or FSH. This is a hormone that's secreted from your brain. It goes to your ovaries and stimulates your ovaries to produce estrogen and progesterone. This is happening in our body from the age that we start having our menstrual cycle. What happens in menopause is that your ovaries have stopped producing eggs, and so they stop producing the estrogen and progesterone to the levels that they were making before. When the brain senses this drop in estrogen and progesterone, it increases the production of FSH, and we can measure that, often diagnose or confirm that a woman is in menopause. So an FSH above 30 is generally diagnostic of menopause in conjunction with the absence of a period. Now, oftentimes women will have had hysterectomy earlier for maybe dysfunctional bleeding, fibroids, those kind of things, or they may have had an endometrial ablation where the lining of the uterus is thinned out due to irregular bleeding. In those cases, we're not going to be able to use the absence of a period to help us diagnose menopause. So in these women, the FSH does provide a valuable clue that a woman is in menopause, again, in conjunction with these other symptoms. Now, if a woman had a hysterectomy and her ovaries were removed at the same time, she goes through something called surgical menopause, which happens with the removal of the ovaries. And that's a dramatic change. And unlike the rest of us that are going through these symptoms a little bit more gradually, women who have surgical menopause go through it very quickly. And hopefully they're able to be on some type of hormone therapy to help alleviate drastic onset of these symptoms. Treatment of menopause can be divided into natural therapies or prescription therapies or pharmaceutical therapies. The natural therapies can include lifestyle modifications, regular exercise, specifically resistance training to help with maintaining our muscle and bone mass, and also to help alleviate some of the mood symptoms and to help balance some of the weight fluctuation and changes that we can see. If women are smoking at this stage, it's really, really important that we stop smoking for obvious reasons like prevention of heart attack and stroke, but also because the vasomotor symptoms could be worse in these women. Reducing alcohol intake may also help reduce the symptom severity. And then, of course, layering your clothes so you can start taking off clothes when you have hot flashes, and adjusting the room temperature at the bedroom temperature so that it's, high 60s, low 70s to help offset some of the temperature fluctuations at night. Cognitive behavioral therapy also helps with some of the mood symptoms. In my reading, I did find that clinical hypnosis reduces the hot flashes by up to 74%. To be honest, I've never had a patient tell me they did this, but that is one of the things out there. Dietary approaches help offset some of the symptoms. One is using plant-based estrogens that are naturally occurring, such as soy. So increasing soy in the diet may have some benefit in reducing the symptoms. Flaxseed may also reduce perimenopausal symptoms. Supplements that often help women transition through perimenopause and sometimes menopause is black cohosh. There's not any studies that show that this is definitively helpful, but many women do describe that black cohosh extract has helped some of their symptoms. Other things that women have reported anecdotally that has helped them, ginseng, probiotics, acupuncture, of course, meditation. These are all things that are valuable for some women. One thing I didn't talk about is the effect of menopause on our muscles and bones. So most of us are building bone until our mid-20s and then experiencing a gradual bone loss until we hit menopause. After menopause, for the first 5 years after menopause, there is a more dramatic loss of bone. We'll talk about how hormone therapy can help offset some of that loss. In addition, this is why the resistance exercise is so important at this stage. Taking vitamin D3, often combined with vitamin K2 to help the absorption, magnesium, and ensuring that you're getting about 1,200 milligrams of calcium daily. The majority of calcium can come through your diet. We are able to absorb calcium effectively, and then the remainder can come through a supplement. Generally, we are recommending against the recommended calcium dosing as a supplement. So to offset some of the bone and muscle loss that happens menopausal years, the most important thing is resistance exercises at least 2 times a week, supplementing with vitamin D3/K2, some magnesium and calcium in our diet and as a supplement. Also in the non-pharmaceutical supplements that are helpful are topical supplements, specifically vaginal lubricants. Women often notice that there's a dryness in the vaginal tissue, and that makes sex uncomfortable. Once you get a pain signal during sex, then our brain is very quick to avoid pain. And so it starts to reduce our libido. So in addition to the hormonal shifts that are happening, you have pain as a negative, creating a negative feedback loop, making us want to avoid sex. So one of the popular lubricants that I recommend to women is Uberlube. It is a silicone-based lubricant, very minimal other additives. It does have vitamin E, and so there's less irritation as far as sensitivity to fragrance and other additives. Then we move on to prescription treatment options. Hormone therapy is the main and most effective treatment option for women going through perimenopause and menopause. It reduces the vasomotor symptoms by about 75%, and it noticeably improves the symptoms of mood changes, sleep disturbances, cognitive changes, and the joint pains. There are different ways that you can get the hormone therapy. It used to be that we would prescribe it as an oral estrogen and an oral progesterone. What happens when you take medications orally is that they have to go through your digestive tract and they have to be metabolized by your liver. So when estrogen is metabolized via the liver, there is a different reactions that happen that can increase what we call clotting factors in the blood, and this can increase other side effects such as blood clots. The pharmaceutical treatment options for menopause can be divided into 3 categories. One is topical vaginal preparations, different from the lubricant. This is a vaginal estrogen that you would use initially every night for approximately a week, and then you would drop to 2 to 3 times a week. So it's not like a lubricant that you have to use prior to intercourse. It's estrogen that's kind of priming the vaginal tissue and improving the moisture and improving the elasticity of the tissue. So topical vaginal estrogen, that's one form of estrogen therapy. That does not relieve any of the systemic symptoms because it has very little systemic absorption. So it's really a local treatment. Second is a topical estrogen in the form of either a patch or a gel. This always has to be combined with progesterone, because if you use unopposed estrogen, meaning estrogen without progesterone, it stimulates the lining of the uterus and creates excess tissue, which can then lead to uterine cancer. So if you have a uterus, meaning you have not had a hysterectomy, then you have to be on a progesterone if you are taking estrogen. And even if the estrogen is a topical form, you need to be on oral progesterone. So it's not enough to be on a topical estrogen and a topical progesterone. It needs to be an oral progesterone to provide adequate balance for the estrogen effect on the uterus. The benefit of doing a topical estrogen as opposed to a tablet form of estrogen is that you are bypassing the metabolism in the liver. And the final form of hormone replacement therapy is an oral estrogen and an oral progesterone. Generally speaking, we have enough data now to show that topical estrogen is safer than oral estrogen. So the default in women who opt for prescription hormone therapy should be that they take a topical estrogen and an oral progesterone. And they can both be taken continuously. You don't have to do 2 weeks on or off or any of those things. You apply the patch usually twice a week or topical gel daily, and then you take the progesterone every evening. Some women have called me recently because there's a shortage of the patch. So I'm trying to switch them to the topical gel. And if neither of these are available, then we may do oral hormone therapy. The non-hormonal prescription medications for menopause symptoms fall into 3 categories. One is serotonin affecting medicines such as Lexapro or Celexa or Effexor. These are really good in helping reduce the mood changes and also the hot flashes. Gabapentin, which is actually a seizure medicine, is used off-label to help the night sweats and the hot flashes. Medications is a neurokinin receptor antagonist. There's 2 medicines in this class, Veozah and Linquet, and they both help reduce the hot flashes and vasomotor symptoms, and they are non-hormonal. So for women that cannot take hormone treatment because of a personal history of breast cancer or a strong family history of breast cancer, they may opt for these other treatments. When women ask me if it's safe to take hormone therapy, I explain that it depends on when you're taking it. The risk changes. Most clinicians now feel that hormone replacement therapy or hormone therapy is safe when taken within the first 10 years of menopause and before the age of 60. After the age of 60, and if it's been more than 10 years from menopause, there seems to be a slightly higher risk of adverse effects. The adverse effects can include an increased risk of breast cancer, can include increased risk of stroke, and an increased risk of blood clots. So what are these numbers? If you are taking hormone therapy within the first 10 years of menopause and under the age of 60, your risk of stroke and breast cancer increases by 0.9 per 1,000 women. So in 1,000 women, there will be less than one extra case, approximately one extra case of stroke or breast cancer. After the age of 60, this risk starts to increase. It does not mean that women above the age of 60 cannot take hormone therapy. It means that we have to explore what their risks of these diseases are at baseline and then have a discussion of whether the benefits of hormone therapy outweigh the risks. To me, this is no different than when you decide whether you're going to take a blood pressure medication or you're going to take a blood thinner or any other medication. Everything comes with a benefit and a risk. This is where I think individualized medicine is so important. We each have to look at these benefits and risks and decide for ourselves if the equation is worthwhile. Because imagine you are going through perimenopause and menopause, you're working full time, you're possibly still raising children at home, you have a partner, and you're trying to do all the things that you normally do, but in the midst of it, you're sweating uncontrollably. You could be sitting in a meeting and it can happen. You could be giving a presentation and it can happen. You find it harder to complete tasks. You're struggling with sleep, and underneath the surface, you are losing bone mass and you're losing muscle mass. both things that can later impact the quality of your life by increasing your risk of fracture and increasing your risk of falls. So when you're experiencing these things, and then you have a solution that carries with it some risk, but that brings more balance, sanity, and comfort to your life now, you have to make that decision. You have to make the decision that's best for you and your family. And just because you start hormone therapy does not mean that you have to be on it for the rest of your life. In fact, just as we just discussed, women can be on it for a year, 2 years, 3 years. If you're doing well on it, you can stay on it for up to 10 years. You can stay on it longer, but you would want to be discussing with your doctor at every couple of years if this is still the right treatment for you. As you've gone through the first 5 or so years of menopause, you might find that you can reduce the dose of the hormone therapy, and that might be enough to give you symptom relief. And going back to talking about the different treatment options. So we talked about topical vaginal estrogen, which gives you relief of the vaginal symptoms. We talked about oral estrogen and progesterone, which gives you relief of the vasomotor symptoms and the other systemic symptoms, and also helps some with vaginal dryness, but not as effectively as the topical estrogen. And then we talked about the topical estrogen preparations like a gel and a patch combined with the oral progesterone, which we now think of as the safest of the estrogen progesterone formulations. And then there is also another category of hormone therapy, which is a combination of an estrogen plus an estrogen receptor modulator. So an example of this medicine is something called Duavi. And this is an interesting newer medication because it doesn't contain progesterone, but the estrogen receptor modulator helps to offset the estrogen effects in the uterus. So there is no increased risk of uterine cancer. The other benefit of this medication, Duavi, is that there is no increased risk of breast cancer. So it's a much safer option for women who may have a family history of breast cancer. For women with a personal history of breast cancer, the discussion has to be more detailed and has to occur with their oncologist. Some women ask about the use of testosterone in menopause. This is also a feasible option, and usually I will think of this as an add-on, or for women who are experiencing significant drops in libido and drop in energy, the addition of testosterone does help. You do have different side effects with testosterone, and that includes masculinizing features such as facial hair growth. And so that may be a trade-off. Also, under the pharmaceutical or prescription hormone therapy, there is something called compounded hormone replacement therapy. These are not FDA-approved medications. These are medications that are formulated by a compounding pharmacist. They can be made into topical formulations or vaginal formulations or even oral medications. So the take-home point from all our discussions on perimenopause and menopause is for you to remember that you are not alone, that you are not crazy, and that there are solutions for the symptoms that you're feeling. So please reach out to your primary care provider or your gynecologist and ask for the solutions that you deserve. I'm happy to entertain any questions that you have, so please use the Google Forms that's linked below and send me your questions. Thank you.